Hypertensive emergency, when blood pressure becomes life-threatening. A 58-year-old man presents to the emergency department with a blood pressure of 230/130, a severe headache, and blurred vision. He is confused, and his urine output has dropped. What is happening inside his body, and what do you do next? Welcome to Medical Sciences Unfolded. Today, we tackle hypertensive emergency, one of the most dangerous conditions in acute medicine, and one where the right treatment within the first hour can mean the difference between life and death. First, let's define the terms. Hypertensive urgency is a severely elevated blood pressure above 180/120, but without end organ damage. The patient feels unwell, but the vital organs are holding on. Hypertensive emergency, by contrast, involves that same threshold of blood pressure, but with acute target organ damage occurring in real time. This distinction drives everything: the urgency of treatment, the route of administration, and the rate at which you lower the pressure. What organs are at risk? The brain, the heart, the kidneys, and the eyes. When blood pressure exceeds the upper limit of cerebral autoregulation, typically around 160 to 170 systolic, the brain can no longer protect itself from the surge of pressure. Capillaries rupture. Edema develops. This is hypertensive encephalopathy, confusion, seizures, and papilledema, a direct window into the brain's vascular health. Now, what causes hypertensive emergency? The most common precipitant is medication noncompliance in a known hypertensive patient. Other causes include renal artery stenosis, primary aldosteronism, pheochromocytoma, cocaine or amphetamine use, eclampsia in pregnancy, and withdrawal from clonidine or alcohol.
So how do you manage hypertensive emergency? The critical rule is this: do not drop blood pressure too fast. Rapid normalization of blood pressure causes ischemia. The brain and kidneys have reset their autoregulation to function at a higher baseline. If you drop pressure rapidly, you strip perfusion from these organs and precipitate stroke, MI, or renal failure. The target is to reduce mean arterial pressure by no more than 25% within the first hour, then gradual reduction to 160/100 over the next 2 to 6 hours. Only over the following 24 to 48 hours should you approach a more normal range. For most hypertensive emergencies, the drug of choice is IV labetalol, a combined alpha and beta blocker that reduces blood pressure smoothly without causing reflex tachycardia. It is safe in most scenarios and easy to titrate. Nicardipine, a calcium channel blocker, is an excellent alternative, especially in aortic dissection, where you must also control heart rate by adding an IV beta blocker like esmolol. In hypertensive emergency with pulmonary edema and heart failure, IV nitroglycerin is ideal. It reduces preload and afterload simultaneously. Add IV furosemide if there is fluid overload. In eclampsia, hypertensive emergency in pregnancy, the drug of choice is IV labetalol or IV hydralazine, along with magnesium sulfate for seizure prophylaxis. Nitroprusside is avoided in pregnancy due to cyanide toxicity. In pheochromocytoma crisis, you must use IV phentolamine, an alpha blocker, before any beta blocker. Using a beta blocker first causes unopposed alpha stimulation and can worsen the crisis catastrophically. Always place the patient in the ICU. Obtain an ECG, chest X-ray, echocardiogram if pulmonary edema is suspected, urinalysis for casts and protein, serum creatinine, and fundoscopic exam. Head CT rules out hemorrhagic stroke. Remember, hypertensive emergency is a clinical diagnosis based on end organ damage, not a number on a monitor. Treat the patient, not the sphygmomanometer. Thank you for watching Medical Sciences Unfolded.